Bismillahirrahmanirrahim. I'm really pleased to be with you today, actually, in this prestigious conference, and I'm really appreciate this generous invitation for this prestigious conference, and I really send my greetings for the organizing committee for this well-organized conference. Bismillahirrahmanirrahim. Actually, today my topic is about a specific type of endocrine dysfunction associated with Down syndrome. Actually, the Down syndrome associated with many endocrine dysfunction, especially this topic today about hypothyroidism. Our agenda today about the epidemiology of hypothyroidism in Down syndrome, screening for hypothyroidism in Down syndrome, management of hypothyroidism in Down syndrome. Actually, thyroid disorders occur more frequently in all age group of people with Down syndrome than in general population. Spectrum of hypothyroidism in patients with Down syndrome include congenital hypothyroidism, subclinical hypothyroidism, acquired hypothyroidism, including autoimmune and non-autoimmune origin. There are 3 major studies reported a similar high prevalence of hypothyroidism in different countries and different age group in adults with Down syndrome. Thus, adults with Down syndrome should be screened for hypothyroidism every 1 to 2 years. A study in UK actually reported that the prevalence of hypothyroidism in Down syndrome in age below 30 years old is around 40%, and above 30 years old is around 50%. Other additional studies in Spain and US give similar reports, as actually below 30 years old from 40 to 43 and above 30 years old from 40 to around 6% of patients. It's not such association, it's more than that, as it's reported by a very good study which reported in 2006 in Thyroid Journal, which is highly impacted journal, that actually concluded that a group of Down syndrome infants have a novel type of persistent mild congenital hypothyroidism, mainly of thyroid origin, and this group characterized by some feature suggestive that a direct relationship between trisomic state of chromosome 21 and the abnormal thyroid hormone production. So, do you think it is worthy to screen or actually search for hypothyroidism in patients with Down syndrome? Actually, it is not actually that easy to detect hypothyroidism in Down syndrome. You should know that the separate hypothyroid patient is similar to Down syndrome in most of features, except that Down syndrome Down syndrome patients have microcephaly and hypothyroidism non-slanted, and also there is no transverse crease in the palm in hypothyroid patient. But if the Down syndrome developed the hypothyroidism patient, definitely there is no clinical differential diagnosis between them, because all of the feature of hypothyroidism are really masked by Down syndrome. You should know that this is originated from actually some skeletal immaturity, giving that large and open posterior fontanelle, also some hypothermia and abdominal distension with persistent umbilical hernia, also the midline facial defect that raise suspicion of thyroid gland dysfunction. Hypoglycemia also may give some clue for central hypothyroidism, also some microcephaly, as we stated, related mostly to central hypothyroidism, and in very low circumstances, actually you may detect goiter in such patients. So it's really challenges. It's really actually difficult to know that many of the symptoms associated with hypothyroidism can be presented normally in patients with Down syndrome, such as constipation, dry skin, developmental delay, and obesity. This means it is difficult to pick up diagnosis of hypothyroidism clinically by your sense and by your clinical aspect with Down syndrome patients. That's why it's recommended for all infants with Down syndrome to be tested and screened for thyroid hormone level at 6 months, 1 year, and every year after that for life. And there's such agreement for that in most of the societies that following the hypothyroidism with Down syndrome patients. Actually, do you think it is worthy to screen for that? What is the importance of thyroid gland? Thyroid gland actually is one of the most important organ in the life of fetus, infant, children, and even adult. Important in that age group for normal growth and normal developmental milestone. If hypothyroidism develop growth and developmental actually milestone will be a little bit slanted and halted. Early diagnosis will prevent that definitely. And it's easy to treat this patient. Only one tablet or a little bit syrup to prevent all these complications that may develop with hypothyroidism in Down syndrome. Actually, you should see is a little bit similar the complication, but it's additive, or in many circumstances, it is synergistic or delayed growth, slow cognitive dysfunction, low muscle tone, and protruding tongue, delayed dentition, delayed fontanelle closure, and dry skin. Also, elevated cholesterol and triglyceride, elevated platelet, elevated MCV, constipation, and even spring disease, low hippocampal volume. It's not that only. Screening is also important to prevent this diagnostic overshadowing syndrome. That's meaning that many clinicians have tendency to attribute symptoms of the person with learning disability to their underlying cognitive dysfunction and their condition, actually, so they underdiagnose the presence of comorbidity with them. So actually, patients are at risk from infancy through adult life to this problem. The effect of the onset of hypothyroidism in children with Down syndrome can be devastating and plateauing or even loss intellectual function of these patients. All this can be prevented by the thyroid blood test, which is part of an annual preventive medical screening for each individual with Down syndrome. We'll actually screen now more than one society they are agreed for the screening of those patients. Actually, in the Global Down Syndrome Foundation, they are stated that screening adults with Down syndrome for hypothyroidism should be performed 1 to 2 years using a serum thyroid stimulating hormone TSH test at the age, starting from the age of 21. Also, American Academy of Pediatrics stated that thyroid screening tests should be annually stating because of the risk of hypothyroidism is around 3 to 5% annually for those patients. Also, the clinical practice guidelines for management of children with Down syndrome, part 1. Actually, it stated that constipation noted in newborn, all of the doctors should be actually alert for feeding process dysfunction. If it is good, at that time, please go for hypothyroidism evaluation. Also, by American Academy of Pediatrics, if the patients have very dry skin, which may be a sign of hypothyroidism, and other skin problems are particularly common in patients with Down syndrome, therefore be attentive to these dermatological problems and discuss them with the patient and the family. Also, congenital hypothyroidism should be detected if newborn screening doesn't include TSH, should be obtained and consider evaluation by endocrinologist. Because of congenital hypothyroidism, actually 1% risk, and actually it is a very good percent, obtain actually TSH concentration if a state of newborn screening only measures 3 T4, as a congenital hypothyroidism can be missed if only the T4 concentration is obtained. The newborn obtained in the newborn screening. Many children with Down syndrome have mildly elevated TSH and normal free T4 levels. So please don't be deceived by normal free T4, and the gold standard for screening for those patients is TSH. So please measure TSH annually. The risk of hypothyroidism is increased with age as stated by guidelines. There's a new definition for neonatal screening by 2021. Actually, guidelines that believing that neonatal screening followed the current National Newborn Screening Blood Spots program for screening for hypothyroidism, and don't undertake additional blood tests for thyroid function or thyroid dysfunction unless there are signs or symptoms of thyroid dysfunction, such as prematurity or sick neonate. Ongoing surveillance should be offered for all infants with Down syndrome for thyroid function tests at 4 to 6 months of age, at 1 year of age, and every 1 year. Also, congenital hypothyroidism, decide whether testing will be venous, like TSH, free T4, and thyroperoxidase antibody, or a dried blood spot TSH, in accordance with the clinical presentation, local arrangement, and taking into account the preferences of the child, young person, and their parents. So actually, what is the finding could be detected by these tests? First, if you did right blood spot test TSH concentration above local laboratory defined normal reference range on surveillance sample. At that time, please offer venous test for TSH, free T4, and thyroperoxidase antibody within 5 working days of the initial blood tests. And please consider initiating treatment while awaiting blood test result if TSH is very high and the clinical suspicion for hypothyroidism. If the initial venous TSH concentration above 10 milliunit per liter and low free T4. So it's similar to the obvious hypothyroidism. Please offer immediate repetition of the venous blood test to measure TSH, free T4, and TBO antibody, actually for detecting any transient hypothyroidism or any interference of the lab results. But consider initiating treatment while awaiting blood test result of TSH if there is a very high if the TSH is very high and there is a clinical suspicion of hypothyroidism. If the initial venous TSH below or within the local laboratory reference range and the free T4 below the reference range, it seemed to be central hypothyroidism or actually a lab interference. So please, for repeat blood tests as soon as possible for TSH, free T4, and thyroperoxidase TBO antibodies. And as soon as you can, seek advice from the endocrinologist if repeated blood test findings show the abnormality persists, as this may be indicate of more unusual form of hypothyroidism or central hypothyroidism, and further patient investigation may be done. If the blood test shows normal TSH and normal T4 but high anti-thyroperoxidase antibody, at that time you should have timing for repeated tests. In 6 months for children and young people aged 3 years and over, if the patient from 1 to 3 months, actually for 1 to 3 months, if the patient aged less than 3 years, and offer repeat the blood test sooner if there is any clinical suspicion. Return to annual surveillance if there are no signs or symptoms to suggest thyroid dysfunction. If the initial TSH concentration above local laboratory defined reference range but below 10 milliunit per liter and normal free T4, it seemed to be subclinical hypothyroidism. So offer an infant, children under the age of 3 years, a repeat TSH and free T4 test in 1 to 3 months, including antibodies in order to ascertain a baseline. In the children age 3 years or above, offer a repeat of venous blood test in 6 months to measure TSH, free T4, and TBO antibodies if there are no clinical signs and symptoms suggestive for thyroid dysfunction, and antibodies are negative. And please return to annual surveillance if 3 consecutive repeated tests showing TSH and free T4 remain stable and there are no signs and symptoms suggestive for thyroid dysfunction. So actually the pattern of thyroid change is important to us in subclinical hypothyroidism. The initial venous TSH concentration above 10 millionth per liter with normal free T4, offer repeat venous blood test to measure TSH, free T4, and TBO antibodies as a TSH concentration above 10 million per liter with normal free T4 is likely to be form of hypothyroidism, but is an advanced stage of subclinical hypothyroidism, and at that time, endocrinologists will actually discuss the benefit versus risk for initiation of the treatment for such patients. If the initial venous TSH concentration above local laboratory defined reference range, but below 10 and low free T4. Offer repeat blood test as soon as possible to measure TSH, free T4, and TBO antibodies. Formulate an individualized management plan for this patient or young person to confirm diagnosis of hypothyroidism, and to consider discussion for this plan with the clinician and expertise in endocrinology department. And in very low circumstances, if the patient showed goiter, so please definitely offer a blood testing for TSH, free T4, and TBO antibodies, and offer an ultrasound scan for this patient, and monitor closely for cervical lymphadenopathy, and seek advice for the endocrinologist if there are any abnormal finding or clinical concern, and don't routinely perform ultrasound surveillance for all thyroid gland patients in absence of goiter, as we should differentiate between glandular tissue abnormality and glandular dysfunction. Actually, there is a different topic and distinctive topics between actually the tissue abnormalities and the function abnormalities. So what is the management protocols for this patient? If we decide to treat the patient with the levothyroxine, it was a 6 months, should be actually the calculation factor from 4.8 to 6 milligram per kilogram, as actually the patient shouldn't exceed around 32.5 milligram per day. Actually, from 6 to 12 months, actually, that factor should be from 4.8 to 3.6. Above 1 year till 5 years, the factor will be lower from 3.6 to 3. If the patient reached actually above 6 years till 12 years, around the age of puberty, at that time we're lowering. Consider it from 3 to 2.4 milligram, and if the patient over 12 years old, at that time he treated like an adult, and the factor around 1.8 to 1.2 milligram per kilogram. Actually, some herbs show some significant actually improvement in such patient, but actually I stated here because I actually always I see some questions about it, and many patients asked me for that, and the clinical data about those is actually sparse. But one of the most of them is ashwagandha, licorice root, actually, and bladderwrack is importantly may have some improvement of the clinical performance of those patients. Please take home message. To summarize, at all age, thyroid disorders occur more frequently in people with Down syndrome than in the general population. if undiagnosed thyroid disorders can be constitute a significant cause of the preventable secondary neurodevelopmental impairment and other health issues, including mental health, e.g. behavior changes, low mood, and anxiety, and depression. Primary biochemical surveillance is essential for early detection and intervention. Thank you.